Now see, we have a drug, we give it to a person, and this particular drug can go through two pathways. Either it can enter into a circulation and then get distributed and ultimately reaching to liver, where it gets metabolized by glucuronide transferase enzyme and cytochromes, and after metabolism it reaches the target tissue or enters the circulation again, and this cycle continues. This is known as enterohepatic circulation. Liver metabolizes the drug reaches into circulation, some part reaches to target tissue, other part goes back to the liver, and this ensures circulation. Hope this is clear. Now another thing can happen, drug reaches GIT, and instead of getting into circulation, it goes to liver via portal vein, and when it reaches liver, it gets metabolized without being distributed. So it is being metabolized without being distributed, and ultimately this would lead to excretion of the drug without therapeutic effects being achieved. So the drug would be waste, definitely a zero waste, if it is given by first pass metabolism. If the drug has high first pass metabolism, its therapeutic effect will decrease or it will be zero, whereas enterohepatic circulation ensures that therapeutic effect is enhanced. So enterohepatic circulation kind of makes the drug long acting, therefore it is beneficial, whereas first pass metabolism is not at all beneficial. We need to use such drugs that are having low first pass metabolism. Now let us take a classical example of two enterohepatic circulating drugs, OCP and rifampicin, oral contraceptive pills, and rifampicin being used in case of tuberculosis. If we give two enterohepatic circulating drugs together, they will compete with each other, and that would lead to failure of contraception, because rifampicin would ultimately compete with OCP. It would be a waste of time and waste of therapeutic effect if both of these are given together. So that is a classical example, and you must also remember that OCP has a half-life of 24 hours. So either if a particular female patient is on OCP and using rifampicin owing to having contracted tuberculosis, we need to suggest her to go for barrier methods instead and not to use OCPs. So post the concept of this metabolism which we discussed, we'll move on to another concept of metabolism, which is enzymes. First, let me clear out my working area. There we go. And let us start our discussion on the topic of enzymes. So see, we have two kinds of enzyme here. Two kinds of enzyme are found in our body: microsomal and non-microsomal enzymes. So these microsomal enzymes, these are inducible. So the drugs which are metabolized by these are more subject to interaction and inhibition, whereas non-microsomal enzymes are not subjected to such interactions, and they are non-inducible. Let us take an example for microsomal enzyme, a classical example of gray baby syndrome. What happens is, we have a baby and we give it chloramphenicol. Oh, I am just sorry, I wrote jaundice here. That's another concept we will be discussing shortly. Okay, so yep. So what happens is that when a baby is given chloramphenicol, it is not having the sufficient microsomal enzymes. The baby is not having the microsomal enzymes sufficient for metabolizing chloramphenicol. So the baby eventually contracts gray baby syndrome. Reason is that the enzymes are absent in baby, which are responsible for the metabolism of chloramphenicol. So toxicity of chloramphenicol occurs here. Must be kept in mind. It's a very important short question asked in general pharmacology testing examinations. Now see, there are two kinds of microsomal enzymes, cytochrome P3A4 and cytochrome P2D6. Cytochrome P3A4 being the major one with 34% concentration. P2D6 is with 19%. Second major metabolizing enzyme must be kept in mind. So let us say if there are two drugs A and B acting on the same cytochrome, getting metabolized by same cytochrome, they will eventually compete and interact. I hope you understand what I mean by compete and interact, as you would have dealt in the chapter of enzymes in biochemistry that builds a kind of concept for such thing. Now post that we have, let me check my notes. Okay, so we have a very peculiar example, a very good clinical example of paracetamol, which is metabolized by our body, and eventually the product is nephrotoxic, and at the very nephrotoxic. Okay, so this paracetamol, if we kind of induce its metabolism, the therapeutic effect is going to be zero, and at the very same time toxicity will develop. The end product is not only nephrotoxic, but at the very same time it is hepatotoxic. So the patient will get to have a therapeutic failure and toxicity if we kind of induce its metabolism. Then there comes the concept of auto-induction. Here, whenever we were discussing about induction, we talked about the concept that there is an enzyme and some inducer is coming and then inducing the metabolism of substrate. But here in auto-inducers, substrate is the enzyme, substrate is the inducer as well. Let us take the example of benzodiazepine, a very great example. So benzodiazepine is a substrate as well as its inducer, its own inducer. So what would happen is, whenever benzodiazepine will bind to its cytochrome for getting metabolized, the remaining benzodiazepine will act as inducer, and benzodiazepine will ultimately get metabolized very quickly. So what you will notice is, owing to increased metabolism of benzodiazepine, therapeutic dose or therapeutic concentration will decrease. So after let's say we start with 200 mg of the drug, within a week you will see that you would have to increase the concentration of benzodiazepine, you would have to increase the dosage, otherwise therapeutic effect won't take place. It's because of the concept of auto-induction. So whenever someone asks you that why benzodiazepine requires increase in dosage post 1 week, auto-induction is the reason for that. Now, what are the consequences of induction? So consequences of induction can be failure, tolerance, toxicity, or dose adjustment would be required, as we saw in auto-induction. Toxicity, as we saw with the example of paracetamol. There is another important consequence which is known as acute intermittent porphyria. It's because of inducers. A lot of porphyrin is produced, which is ultimately toxic for body. So we need to adjust the dose to counteract it. Now, what are the uses of induction? How can we use the wisdom of induction? See, induction is a very beautiful concept. It can also increase the therapeutic effect of a drug. So how can we bring it to use? So see, what we can do is, we can take a very great example of jaundice. You would be knowing from your knowledge of physiology and biochemistry that jaundice, in treatment of jaundice in children, we give phenobarbital. Though phenobarbital is an anti-epileptic drug, it has no role in jaundice, but still we are using it. Jaundice is increase in bilirubin levels. So if phenobarbital is an inducer, so it kind of increases the breakdown or metabolism of bilirubin. So jaundice gets reversed. That is the significance of using phenobarbital in the case of your jaundice. Similarly, in case of Cushing syndrome, we use inducers, so that kind of increase the metabolism of steroids, and that helps us in reversing Cushing syndrome. Now post this, let us discuss the concept of excretion. Let me clear up my working space, and there we are, good to go with the topic of excretion.